I wish I knew what was coming in.
Really stresses me out.
We are very, very organized chaos.
Let's go.
Hey guys, welcome back to the channel. Maddie here, and I am here with my friend Liz, who is an ER nurse, and we're here to talk about ER versus ICU nursing. So for starters, ER versus ICU. As far as nursing goes in general, we go through the same schooling. We work the same amount of hours. I work a 12-hour shift. I'm assuming you work a 12-hour shift. I'm on days, you're on days.
Also.
So for the most part, that is the same. It's just depending on which specialty and which area you want to work in.
So in talking about ER nursing, like we are very, very organized chaos versus ICU being organized in all aspects, in all things. When we have our patients, we're assigned 2 rooms and we have 4 beds. So we take whatever's in those 2 rooms. Sometimes we'll have 2 ICU patients, but we still have 2 other patients that we have to worry about. So really, we're just trying to make sure that everyone A, stays alive, and B, is stable enough to make it up to their units, especially the ICU.
Yeah, we only have 2 patients max. We have, if it's a really sick patient, a 1-to-1, then we only have 1 patient. That could be post-code, that could be CRRT, ECMO, anything that's specialized, balloon pump. So the fact, like the thought of having 4 patients, whether it be ICU or not, really stresses me out. So that's crazy that you guys can have that. Like you could have more than 2 ICU patients at a time.
Yeah, and it honestly, it stresses me out too, because like being in that situation, I know I should do so much more for my ICU patients. Like we were talking about before, I wish I could turn my patient.
Yes.
I really want a turning schedule. Whenever I have my ICU patients, I try to make them as ICU as possible. I try to label my lines, try to turn, try to do all my scheduled medications, but it's so chaotic. Like your hands are tied at some point and you can only do so much.
And I find like for our hospital especially, like if I'm getting a report on a patient that is coming up to me, sometimes that nurse will also be the trauma nurse that's on. And if a trauma comes in, I get my patient and I can see like, you know, this med wasn't given, or maybe it was given late, or this wasn't charted yet. But it's not because the nurse was lazy or couldn't get to it. It's like changing your mindset and thinking, okay, well, they had something they had to go do. They had a trauma coming in. Like your priorities are a little bit different focused. For us, it's like we come in, we know the patients we're gonna have all day. It's the 2 people, we can look them up. I know their history, like everything that is planned for the whole day, I can schedule myself. Like you said, turns. We turn our patients every 2 hours. We clean their mouths every 2 hours. We give them baths. You know, we have to focus on the details of what it takes to take care of them for a whole day. Whereas you guys have to focus on getting them stable and getting them where they need to be.
Yeah, and like how you're saying, you know your patients for the entire day. Like that's a blissful situation. I wish I knew what was coming in. Like if I could have that little God's eye and find out what was coming in the next hour or so, it would be so much easier to be able to handle my patients, prep up. And we know we have that little red phone where they call in for emergencies, like full arrests that are coming in, people who are having trouble breathing coming in, but sometimes you don't even get the red phone. You don't get that courtesy call and they just drop in on you. So you have to be ready for anything. And it would be so nice to have like a little schedule and know, oh, my patients are coming in at this time and be ready for them, but sadly can't happen.
Yeah, and I feel like a lot of times, like I'll get a patient from the ER and because they were so sick or whatever it is, you don't have time to do that, like searching and learning about the patient, like you said. And sometimes, you know, you have to assign them a name that's not theirs. You can't find their wallet. Like then when they get to us, our social worker can start working on that and finding family and especially if it's a post-code or anything like that, we need to get the family involved and learn who the patient actually is. And so we can do that once they get into the ICU.
And that's one thing that I feel always super sorry about. Like I can't always find family, especially if it happened out on the street, the patient wasn't with anybody and I can't find the family. So the ICU nurse that I'm giving a report to will ask like, oh, well, has anyone come in? Have you been able to find family? It's like, no, I don't even know this guy's name. I can't figure that out. Yeah. All I know is he's stable now, so he's coming.
Yeah. Another thing, I don't know if your hospital does this, but for our hospital, our ER nurses bring our patients to us. Is that something that you guys do as well, or does your ICU nurses have to go down?
No, we definitely go over with the patient, especially since I mean, it would be great for the ICU nurses to come down, but I totally get it. You guys have your unstable patients as well. So I'm worried about, oh, if I send that patient and they code on the way, I just feel so responsible for it. So we usually transport our patient over to ICU.
Okay. So as far as the layout of your unit, what would you say? Is it set up a certain way? Is it like organized a certain way?
Yeah, so organized chaos, obviously. So we try to keep the chaos as organized as possible in the sense that we have 3 separate areas. So we do one area, which is fast track, another one, which is ED1, and then ED2. So we have about almost 50 beds, last I counted, I think. But we have 2 triage nurses. So one will triage people who come in through the waiting room, and then the other one will triage the paramedic runs. Because it would just be way too much for one triage nurse to handle on her own. And also that way, if anyone comes in who's really unstable, we don't want, you know, the little kids that are in the waiting room waiting for like a bandage to see that and get traumatized. So we try to keep them separate. And in fast track, we handle mostly like lacerations, broken bones, small urgent care emergencies, and then in ED1 we try to keep it to like abdominal pain, chest pain, nausea, vomiting, stuff that is unstable but not so unstable that they need to go into our more critical rooms. So ED2 we try to keep it to critical and completely unstable. So we have one trauma room that has 2 beds in it, and that one has our trauma cart, our like biggest crash cart. It's set up basically for full arrests and anyone who's very unstable and needs like immediate care. And that's usually when our little red phone will ring and tell us like, we have a patient who's coming in, full arrest, found down for however long, and then they'll tell us 5-10 minutes that we'll hang up the phone, and then we prep up for that patient. So we'll have the whole team in there, getting the crash cart ready, getting the trauma cart ready with whatever we need. Like, God forbid it's a peds case, so then we'll get all our peds stuff in there. We'll call the NICU, they'll send down their neonatologist, and we just get the whole team ready with that small amount of like window time that we have.
Okay. So we are a little bit different, and I'm sure every ICU is different, but for our ICU, all of our rooms are pretty much set up the exact same, have the same materials in them. Us nurses actually set up our room. So after we have a discharge in a room, we strip our room, it gets cleaned, and then we have to restock it with everything that we're going to need, suction, any like linen that we like, chucks, we zero our beds, so that's ready. And as far as like the actual rooms where we place people, for the most part, it's whatever room is open is where the patient's gonna go. However, if we know ahead of time that it's an open heart surgery or we're planning for an ECMO, we do have certain rooms for those. We have a corner room that we save specially for ECMO because it's large enough to hold all the machines. And then we like to keep our open heart patients close to the nurses' station so we can see them. It's easier to get into the rooms. But overall, we don't have, you know, a system where it's like these certain patients, GI patients, heart patients have to go in certain rooms. It's whatever is open at that time. So as far as working with doctors, NPs, PAs, all of that, how does it really go for you guys in the ER?
So we have a constant rotation of doctors. We have one that stays in ED1 and one that stays over in ED2, and they're on alternating schedules. So there's always at least one doctor on duty, and more often like throughout the shift we have 2. And then we have one constant PA or NP that's taking care of the fast track patients in the urgent care side. So we're always with an influx of doctors and PAs. So there's always someone there to help. And then we have our specialty doctors who come in depending on the case, whether it's neuro, GI, anything like that.
Okay. So our hospital does a 6 to 6 schedule for our doctors. So our intensivists come on, they're there all day. They know all the patients in the ICU. Occasionally, some hospitals have the NPs, PAs that we can also turn to. But for the most part, it's just our ICU doctor who's there, and they switch out. We have about 5 of them who switch out day to day and nights versus days. Other than that, we also have our specialists who come in. So if we have a neuro patient, we have our neurocritical care team. If it's a renal patient, we have our renal team, and cardiac, you know, go on and on. So they come in and see them as well. All right, so knowing what you know and hearing what we've told you, if you had to pick between ICU or ER nursing, which one would you choose? Comment below and let us know. And as always, if you like this video, make sure to give it a thumbs up, hit that subscribe button so you don't miss any of our videos, and see you guys next time. And as always, and see you guys next week. Hit that subscribe button so you don't hit us.